I'm going to continue with the respiratory assessment, but I just want to remind you that when we assess the respiratory system, if you go back to your assessment class, we definitely start with inspection. We look at the front and the back of the chest. We look for that anterior-posterior kind of view where we see the whole, proximity and diameter of the thorax. That anterior, posterior, or front to back with the lateral side to side, where the normal should be a 1 to 1.5, and sometimes that ratio starts to increase, as seen in our patients who have emphysema or barrel chest. With that, what happens is over time, with the retention of CO2, the ribs start to slant down normally, and the ribs become more horizontal with COPD. And then after inspection, we palpation. We check respiratory movement and symmetry. We check for areas of tenderness, check vocal and tactile fremitus, vibrations. And if you think about it, remember what tactile fremitus is. It's that vibration of the chest wall when a person speaks, and you can feel that vibration on the chest wall. And why is that important? Well, when it's normal, it really doesn't, tell you too much. It's when we have less fremitus, that means that transmission is slowed from the larynx to the chest wall, and problems can occur when the pleural space is filled with air, such as like a pneumothorax or fluid, like a pleural effusion, maybe when the bronchus is obstructed from mucus, or fremitus can be increased with pneumonia, lung abscess, because the density is increased of the thorax, and it enhances the transmission of sound. Remember, sound travels better through fluid. And then, of course, we do percussion and auscultation, okay? So I just wanted to remind you that we don't want to lose those basic skills in when we assess, especially a system of this great importance, okay? So I just wanted to kind of go over that with you and kind of think about the importance of inspection, palpation, and percussion or auscultation. All right, lastly, to finish up the respiratory system, I want to talk a little bit about the endoscopic examination, such as a bronchoscopy, a thoracoscopy, a laryngoscopy, a mediastinoscopy, a thoracentesis, okay? So I just want to kind of go over these because, like I said, we don't always know, exactly how to do that. It's just important to know what is my role as the nurse when these diagnostic studies are ordered for our patient. And probably two of the most common ones is a bronchoscopy and a thoracentesis. And these are very invasive diagnostic studies, okay? And we'll just talk about that in a minute. All right. First, we'll talk about the thoracentesis, okay? And the important thing is to think about, okay, my patient's going to have a thoracentesis. Where is the location of that invasive procedure going to be at? Well, it's going to be in the pleural space, okay, not in the lung. The needle will be put in the pleural space, because if we put it in the lung, what would happen is it would cause the patient to have a pneumothorax. A thoracentesis can be done for many, many reasons. They can remove fluid. They can pull out the fluid to analyze it to see if there's any certain organisms growing in that pleural space. They might want to do a pleural biopsy, or we can also instill meds in that pleural space, okay? And what it basically is an aspiration of pleural fluid or air from the pleural space, okay? And many times we see our patients acquire pleural fluid from cancer, emphysema, pleurisy, and the reason this has to be done is it has an excessive amount of pleural fluid in that space, which really hinders expansion of the lungs, and that's what causes our patients to have poor gas exchange, respiratory distress, dyspnea. And, you know, it can also help in regards to the draining of that pleural fluid to relieve the compression on blood vessels and even on the lungs, okay? With this test, you know, patient positioning is everything, okay? Definitely want to explain to the patient what's going to happen, okay? Before they insert or get into that proper pleural area, they're going to numb the area with some kind of Novocaine or lidocaine, okay? And once the physician is going to attempt to get to that space, and many times, you know, in order to avoid any complications from it, the physician may do this under fluoroscopy, so we know that we're going to hit that exact pleural space and not accidentally hit the lung, okay? It's very important that we teach our patient to not move, avoid coughing, deep breathing, because it can cause puncturing of the pleura or actually the lung. We want the patient to be comfortable, and our role as a nurse is just to be there for moral support, and obviously have everything ready for the physician who's doing this, hopefully all the equipment, the bottles that drain the fluid, so that everything's you know, put in the correct containers so it can be sent down for to the lab for the necessary studies that the physician orders. Patients will have to sign a permit because this is an invasive diagnostic test, okay? And so, like I said, it can be done by bedside. It can usually be done by the bedside, okay? And like I said, many times the physician will get either CT guidance or fluoroscopy or something like that. Our goal is to just really watch the patient during the procedure, make sure he does okay or she does okay, watch for any signs of shock, excessive pain, nausea and vomiting, or pallor, or they might have like a vasovagal type of reaction to the procedure. Usually the needle is about an 18 or 25 gauge needle, and what they do is, you know, get the correct area, and then they just let it drain by gravity, and your role is to just kind of observe the patient as that fluid is draining. The book talks about not draining more than 1,000 mLs, but some of your physicians will let more than that drain if the patient really has a large amount of pleural fluids build up in there. And then once that's drained, what they actually do is they insert the needle and they kind of cannulate it. They pull the needle out, and all it is in the patient at that point in the pleural space is more like a plastic tube. And then once, you know, the patient's drained as much as the physician wants him to, then they'll pull out that cannulation and apply pressure and just put a small sterile dressing on it. After the procedure, they want to make sure the patient's stable. You'll do the assessment, probably do their vital signs, make sure they're not having anything like excessive pain or their color looks good or no respiratory distress, indicating maybe the patient developed a pneumothorax during the procedure. They'll probably do a chest x-ray because they want to rule out a pneumothorax or even a mediastinal shift, any kind of possibility of pulmonary edema or any excessive amount of pain, okay? And you as the nurse will document the procedure and send specimens to the lab correctly. If a pneumothorax is going to happen, it's usually going to happen in the first 24 hours. You know, just kind of assess the puncture site, just kind of feel around to make sure that you're not feeling any sub-Q emphysema, because that would feel like, you know, popcorn, you know, because that means there's air escaping in the subcutaneous tissue. If they're having really a lot of pain on the affected side, if you notice their heart rate is going up, or if they really seem to be short of breath and kind of developing air hunger, or that we see some type of tracheal shift. We also worry about infection because it is an invasive procedure. The patient is not gowned, but when the physician was doing the procedure, it should have been done under a sterile field. He should have wore a mask, and not necessarily a mask, but a sterile gown, sterile gloves, because it is a sterile procedure. And usually put sterile drapes around the patient, around the bed, to be sure that he kept a good aseptic technique. Okay. And so we also worry about a tension pneumothorax, where there's a buildup of air, and that really is an emergency. But the important thing is you as the nurse needs to make sure that the patient is in that correct position and that they're not moving. As you can see, they kind of lean over the bedside table, and it kind of opens up those pleural spaces so that the patient, the physician can reach that area a little bit easier. They're very nervous, not only about the procedure, but maybe what's going to be found in the analysis of the fluid that drained out. So, you will definitely assess your patient's hourly vitals, or maybe every 30 minutes for the first hour, and just make sure the patient does okay, and just watch for any of those impending complications, such as pneumothorax or any type of changes in their heart rate or in their respiratory status, okay? And then, obviously wait and determine, when the results come back so we can make more of a diagnosis of, what is in that fluid sample. A lung biopsy is, just for obtaining some kind of tissue for histological analysis, culture, or cytologic examination. This is probably a test that they're going to do, again needing a permit because it's an invasive procedure. Usually we'll do it under fluoroscopy because we sure don't want to hit a major vessel in the lung and cause bleeding or hemorrhage. Many times they might do this because they might suspect cancer, or they're not sure about why the patient has a shortness of breath. So they'll do a lung biopsy. So the big thing with that is to, follow up and make sure there's no distress, auscultating the lungs to make sure there's no absent breath sounds, which could indicate a pneumothorax, and then monitoring for hemoptysis, which could indicate that they've hit a big vessel and the patient is having a lot of coughing and bringing up a lot of blood. Pleural biopsy, lymph node biopsy, especially if the patient had some kind of cancer and they're suspecting metastasis. I just want to go back to, so that's what you're watching with your biopsy. You're watching for infection, hemorrhage, and any respiratory distress. I just wanted to go back to the bronchoscopy because that's another common invasive diagnostic study that they'll do. Many reasons for a patient having a bronchoscopy. Again, an invasive procedure where they're going to have the patient sign a permit. Again, always explaining the patient, and that should always be done by the physician, the one who is actually doing the procedure. He may want to do it for reasons of removing foreign body, removing secretions, treat post-op atelectasis, destroy and excise lesions, or maybe insert a stent to keep that those bronchioles open. Now remember, when you have these invasive procedures, always review your patient's medications, because many of these patients are on anticoagulants, and they're going to probably hold those before the procedure, or maybe not give a recent dose because we don't want to increase chances of bleeding or hemorrhage. Excuse me. Obviously, assess patients' allergies. do a CBC, platelet count, PT, electrolytes, and see chest x-ray. They're usually NPO for 48 hours. They're usually taken down to some special area, like special procedures or something, because you figure you're putting something down someone's lungs and their bronchioles, they're going to have a significant cough reflex. So we do have to sedate these patients very well so we can keep the tube down there and really do what we need to do while we're down there, or while the physician's down there. They might give a benzocaine spray, oral pharynx, or they might use lidocaine for fear of the patient developing that methemoglobinemia, which can be a very serious side effect if they use the benzocaine spray. The thing is, the patient will have a fair amount of sedation just to keep them quiet, preventing them from coughing, preventing them moving, so they can get that tube down and visualize or do what they need to do, depending on why they're doing it in the first place. The big thing is when they come back to the room, you don't want to be giving them anything to eat or drink until they're fully awake and that their gag reflex has returned. So just kind of instruct families not to go ahead and try to start giving the patient water when they come back to the room, because maybe that gag reflex has not returned wholly, and we don't want the patient having any type of problems with aspiration or anything like that. So that's a bronchoscopy, okay? And what they'll do is if they're doing a biopsy, they'll examine those tissues or collect those specimens. Maybe they suspect a tumor. And that bronchoscopy will also help to determine if the tumor can be resected surgically, and maybe the patients had hemoptysis and now they realize what the reason was why the patient did have hemoptysis. So that is, like I said, one of the more common diagnostics or invasive procedures, that and thoracentesis. And then they on occasion will have to do a lung biopsy. Okay, so that pretty much concludes the respiratory assessment. You really need to read these over and kind of understand and absorb what that assessment is all about, especially with such an important system as the respiratory system, and really to understand the terms. And I'm going to provide a focus sheet kind of pointing out what I think are the important terms and concepts from this particular chapter. And when you see those terms or concepts, I want you to really understand what that means and why is that important for me as a nurse in regards to my patient who might have a respiratory problem or is at risk for developing a respiratory problem. So I'll provide those along with these lectures, these focused assessment papers for each day of lecture that we're going to have during the whole time of the summer with Nursing 210, just so I keep you aware of the important aspects of the chapter so that you can go back and review it, and you can go back and just really say to yourself, do I understand what this chapter is telling me about this particular word or term or concept? And it will really be a great aid in helping you process the information and also prepare you for the respiratory test. So thank you for your attention, and we'll continue on with the next chapter.